So the title of my talk is What You Can Do to Prevent the Complications of PXE, and I will address everything certainly that I know and hopefully some future things as well. I am now the Dean for Clinical Therapeutics at Mount Sinai. I have been chairman of the Department of Dermatology for almost 24 years, almost 25 years, and stepped down to be a dean, or stepped up to be a dean. So this is where I work. You see in the lower left-hand corner, New York Central Park. That's Fifth Avenue over there, and the Mount Sinai Hospital Complex. And I have been there since my internship, where I came thinking I was going to be a cardiologist, very enthusiastic about it. At the time, the editor of every major cardiology journal was a doctor at Mount Sinai, and they had a world-famous department, and I was very enthusiastic about it. And still listen to hearts, especially my PXE patients, and still am pretty good at reading EKGs. But something happened along the way. So let me tell you that I practice in New York at Mount Sinai. Here are some of our sites. Actually, one of the big draws and the reason we've been able to get patients in clinical trials for PXE is the grants that we put out for PXE. We're always able to fly the patients in and they get to stay in New York for a day or two. So it's been fun for the patients, I hope. I bring you regards from the two most important people in New York, my grandchildren. And I'm going to move on to November of 1979, when I saw this patient, first PXE patient I ever saw, and she had these redundant folds of skin. The dermatologist whom I saw with her knew what it was right away. He was the chairman of the department back then.
Also, sorry to interrupt. Can everyone see my slides?
Yeah. Oh, and I apologize, Georgia. I apologize. I'm going to say next. I'm looking at my computer and realizing that I'm not foreign. So, do you all see a neck there with redundant folds of skin?
Yes, we do.
Okay, great. So that is November 1979, the first patient I ever saw. And he told me she had pseudoxanthoma elasticum. At the time, we didn't know if it was an elastic tissue disease or he was a world famous collagen expert. And there was some thinking that it would be a collagen disease. Because I was going to be a cardiologist, I listened to everybody's heart. And interestingly, in this photo, she is 8 months pregnant. And she had a loud murmur of what we call mitral valve prolapse. And that is a murmur that is supposed to disappear during pregnancy. And hers didn't, because it was so profound that it was still quite loud. That it did indeed intrigue me. And you can see that she has this very hyperextensible skin on her neck. And we did get a biopsy and proved that it was pseudoxanthoma elasticum. But the heart murmur really intrigued me. It had not been reported in pseudoxanthoma elasticum. And so back then we didn't have computers, and I sent letters out to all of the cardiologists at Mount Sinai and all of the dermatologists at Mount Sinai, and I asked if any of them had patients with this. And I ended up calling those people. Again, we didn't have computers, so it was all by phone. And I managed to get 18 patients in, and 2/3 of them had that murmur. So that ended up being published in the New England Journal of Medicine, which is not an easy place to get published, and is viewed a lot. And so suddenly people knew that I had an interest, and I started getting calls from patients. And I will say that over the years, since 1979, when I first saw her, I have seen over 1,000 patients with PXE. A high proportion of them do indeed have heart murmurs, usually mitral valve prolapse. But it really blossomed my interest in the disease, and ultimately was one of a number of reasons that I ended up becoming a dermatologist rather than a cardiologist. So I do owe PXE for that. And I actually have had several New England Journal of Medicine publications over the years. The first was that mitral valve prolapse publication. We were then able to show that there were patients who did not have obvious skin lesions of PXE, but they had angioid streaks, which is the eye hallmark of the disease. It's what you see in the eyes of PXE patients. And they had had heart attacks at early ages, even though they had no skin lesions. And we were able to show that indeed they had PXE by biopsying the usual sites where you find PXE. Usually it's the armpit or the neck. And we'll speak a little more about that. We then were able to show that in patients who didn't have characteristic skin lesions, PXE was known to occur in scars. It's something called a Kebner phenomenon. Certain disease will turn up in a scar. Well, we had seen in some of the patients yellow lesions like PXE. So we started biopsying scars in patients who we thought might have PXE, but didn't have characteristic skin lesions. Most often what they had were angioid streaks. By the way, pardon me as I'm looking at my screen rather than looking at the telephone. So we found that by biopsying scars, we could diagnose PXE in a large number of patients. So that was published there as well. And ultimately, we've even done things like finding by biopsying the lip, we can also often diagnose it. And I'll show you a picture of that in a short while. I teamed up with a man named Yoni Wito, and I will say, with some sadness, he was really a hero of PXE. He was the individual who, using samples that I accumulated from many of my patients, was able to identify the mutation, which is an ABCC6 mutation. He showed at the time it was autosomal recessive. Turns out it's a little more complicated than just autosomal recessive. But the bottom line is it involves that gene. And then it turns out that there can be other genes that are involved as well. It's called genetic heterogeneity. But it for sure you need two abnormal genes in order to get the disease. And what we see under the microscope when we biopsy patients is calcium on elastic fibers. And normally when I show you a biopsy of the skin, you never see the black stuff that you see here. That is a stain called the von Casa stain, and it specifically stains calcium. On a normal skin biopsy, you would see zero calcium. Just not normal to see it there. In PXE, we see a lot. And to me, that is the diagnostic test that is used most often. And especially because there is this genetic heterogeneity, biopsy is actually a better way of definitively diagnosing it than a genetic study. But many of the studies we do today require genetic confirmation of PXE. So I told you it was calcification of elastic fibers. The stain that you see here is called an elastic tissue stain or a Verhoef-von Giesen stain. And what you're looking at are these nice normal elastic fibers in a normal skin biopsy from a patient who does not have PXE. And what you're seeing here are these clumped, fragmented, calcified elastic fibers in a patient who does have PXE. And that does appear to be the reason that we get many of the changes that we see. So, for example, all of the places where PXE turns up and causes havoc are places that have elastic fibers. For example, the skin. And the most common site to see it is on the neck. The second most common site to see it is in the armpit. And it usually goes to what we call flexural areas, areas where skin bends on skin. So, your neck bends from side to side, your armpit bends up and down. The antecubital fossa is the area opposite your elbows, and you see that those yellow dots there, that's PXE. Also the area behind the knees, which is called the popliteal fossa. We see it there. And I'm not sure, and there on the left, you're looking at a neck. On the right, you're looking at, and this is a 33-year-old woman. And I don't know why, the groin also is an area where, your skin bends, so you might expect to see it there. But I don't know why the periumbilical area, the area around the belly button, is a flexural area, except maybe in belly dances or people who do a lot of sit-ups. But we typically see it in the periumbilical area, the area around the belly button. So very common sites of involvement. This patient is 33 years old, and she looks like she has the skin of a 90-year-old. And actually, you can tell from looking at her, she's actually in very good shape. She's an exerciser. She's not overweight, but she's got the skin of a 90-year-old, despite being an exerciser. So the other places where you have elastic fibers are in a membrane that is behind the retina, which is called Brooks membrane. And what happens in PXE, and I think you can see it beautifully in this African-American patient. This is actually that 28-year-old patient whom I saw first. And you see these dark lines. Unfortunately, you're not looking at my laptop, so I can't show you where they are, but they look like these brown streaks behind the retina. What they represent are cracks in Brooks membrane that has elastic tissue because it becomes calcified and cracks. And what happens in PXE, new blood vessels form behind that Brooks membrane. Those new blood vessels are not normal. They leak a lot. And if they grow through the membrane, they actually change the shape of the retina. And so that by changing the shape of the retina, they make your vision change so that straight lines look wavy. And I will show you an example of that in a few minutes. But that's very obvious angioid streaks. When they happen in a blonde patient, they really, they look like, and this is a patient whose vision has not yet been affected. But you see they're red, more reddish, and they look more like blood vessels. The word angioid means blood vessel-like. And if you look at sort of the top of center area here, you see a bleed. A patient has bled from one of those blood vessels, but still this patient has 20/20 vision. So the other place where there's elastic tissue, and I will tell you, we're getting ready to go into cardiology. I had no idea that the heart valves have a lot of elastic tissue in them. And it's interesting, way back then in the early 1980s, I did a literature search and I looked at every publication on PXE that existed. And in one of the publications, someone had shown a Vierhoff Van Giesen elastic tissue stain of a heart valve, and they said that it was collagen, but they were wrong. They were looking at a beautiful picture of elastic fibers in a heart valve. So anyway, besides the heart valves, and that's why you get those heart murmurs, and I'll show you in a moment why you get the heart murmurs. The coronary arteries have an internal elastic membrane, as do all of your arteries. And so when you feel your pulse, you can feel it in patients who don't have PXE. You can feel it go up and down, and you can count a heartbeat. You can count a pulse. In patients with PXE, we often are not able to feel the pulse because often the internal elastic lamina, the middle lining of the artery, which is the one that goes up and down when you feel a pulse, becomes calcified. So you often cannot feel pulses in patients with PXE. Not all the time, but in advanced PXE in an artery, you can't feel the pulse. So the coronary arteries also become calcified, and that's what we call hardening of the arteries. And when they become calcified, the arteries can narrow and they can close off, and that's what causes a heart attack. And there are indeed, here you see a 16-year-old, an 18-year-old, heart disease in a child, sudden death. That was a report of three, I think it was 3 Australian teenagers who died of heart attacks. And, whenever I hear on the news that some athlete died of a sudden heart attack, I always wonder if they didn't recognize PXE because it can be a cause of that. Having said all this, I want you to not be frightened because, the average lifespan of a PXE is not that different than normal people on average, than people without PXE. So Way back when the lifespan was in the high 60s for the average American, it was in the close to 60, it was in the high 50s for PXE patients. Fortunately, it's gone up in both groups, PXE patients and patients without PXE. Okay, so let me review this again. The skin is typically involved. Involved, and you see this calcified elastic fibers there, and calcium in the skin. The eyes, the internal elastic lamina, that black that you see, is calcium inside an artery. And that's what you're looking at in that item F. And when you take an X-ray, you see the bones fairly obviously, but then you see these kind of ratty white lines next to in the thighs above the knees and in the lower leg. And those are calcified arteries. That's because the internal elastic lamina becomes calcified. So calcification of blood vessels is a real problem because the blood vessels get narrowed. So what are the implications of that? When you get calcification of the blood vessels of the leg, you get something that we call intermittent claudication. You might be able to walk just half a block and your legs hurt because the circulation is compromised. So that's caused by that calcification of the arteries that you get in PXE. The other thing that can happen, and those arrows are pointing to those calcifications in the arteries. I'll get to this in a minute, but the other thing I'm going to show you in a moment is the other thing that can happen is those calcified, I'll go back one slide, those calcified arteries can crack and bleed. And so, as we'll talk about in a short while, there are numerous reports of GI bleeding in patients with PXE. Some of the people on the phone may have had that. There are reports of bleeding in the skin because an artery in the skin breaks. There are reports of uterine bleeding, particularly after labor and delivery. But even without labor and delivery, there are reports of uterine bleeding. There are reports of bleeding almost every organ, including the brain, although fortunately that is uncommon. But bleeding can occur. So here is a typical PXE on the neck. And we did come up with a grading system for PXE. So when you get those yellow, we call them papules, those yellow dots, when they become confluent, that's given a grade in our system of 2. When you get the redundant folds of skin, which I'll show in a moment, that's a 3. When you have just isolated papules, that's a 1. And you see here a 1. It's kind of faint. It's hard to see those yellow papules, but we do grade that. Here, the papules are starting to become confluent. So it's between a 1 and a 2, like a 1.5 this would probably get. And here are the redundant folds of skin, which is given a grading of 3. And we do that in order to help us assess whether PXE is getting better. And this will become more and more important as new drugs come out. And we finally are on the cusp of a couple of drugs for PXE, which hold real promise to helping the disease. But I told you I would tell you what you can do to prevent the complications. So one of the things that you can do is there are plastic surgical procedures that are quite effective. And you're looking at an old published article by a plastic surgeon before and after, and look how those extra folds of skin have disappeared following surgery. So very successful surgery there. The armpit isn't the second most common place to get it. And here is a publication with the extra skin removed from the armpit. And we've had a number of patients having this done at Mount Sinai. The periumbilical area and thighs, I've told you, and we have patients who've had that done, both of those done as well. Here you see, this would be called a abdominoplasty. They cut away the extra skin of the belly, and it pulls the PXE tight so you don't see it. Now, the other place where you get PXE is on mucosal surfaces, because they also have elastic tissue. And in fact, sometimes somebody will go through an endoscopy or a colonoscopy and they'll have biopsies done, and the pathologist won't understand when they see these clumps of elastic fibers there. And what they're looking at is PXE in the gastrointestinal tract. So here you see it on the lower lip of a patient, and it is, by the way, very, very common there. And the appearance that goes with that is this reduction in jawbone size and extra skin of the jaw, which causes what is called a mental crease. Mental is the word for chin, and you get this little fold across the chin. In this woman, it looks something like an H. That is, by the way, very characteristic in PXE. You can see that in older patients, but in PXE patients, you often will see it in their 30s, 40s, and 50s, not in their 80s, 90s, and older. So that is another feature, and you see it here again. That sort of fold across the jaw with the lines at the side that make it look almost like an H. So we actually published the use of the first filler, which is collagen, and you see here a before and after. And it's not perfect, but there's a big improvement, and the patient actually was pretty happy with that result. So we've done this. I'm not a cosmetic guy, but we have a whole cosmetic team that does this and does it well. So that is fillers for collagen. Nowadays, we use hyaluronic acid fillers. The second thing I'm going to talk about, and I want to give some points to Wayne Fuchs. And actually, I'll tell you the story of how I met him. Wayne and I were interns and residents together. And I actually, one of the things I admired about him, I was on call and came in, in the middle of the night. And there he was. He's already an attending physician, as I was, and he's wheeling a patient himself through the halls of Mount Sinai to get them in the middle of the night to the correct X-rays that they needed. And I always admired that about him. Incredibly nice guy. I actually happened to one day be passing his office, which is in Midtown Manhattan, and I saw him actually literally wheeling a patient from his office to a taxi to put them in. So he's a great heart, but he's a great doctor. And I had seen a patient who had angioid streaks, and we proved that the patient had pseudoxanthoma elasticum, and she brought a relative who didn't have any skin lesions. But, we often have learned that often the eye changes occur before the skin changes. Not always, but often. And so I would routinely send the relatives of my patients to a retina specialist. And there were a few that I used. And one was Dr. Fuchs. There's also a guy, Marty Uram, was excellent. And Larry Yanuzzi, very famous. Also a guy named Stanley Chang. These were like the most famous retina specialists in New York. And here's Wayne Fuchs. He's honestly a little kid compared to them. And this patient, knowing she has a family history of PXE, had gone to the head of retina at Mass Eye and Ear, which is the place where I trained in medical school. So went to the most famous retina specialist in the world, and he said she had nothing. I sent her to Wayne Fuchs, and he showed me that hiding behind a blood vessel on her angiogram, you could see an angioid streak. And we ended up, she didn't have skin lesions. We ended up biopsying normal appearing skin on the neck. And indeed, we saw classic PXE in her. And I had after that several patients with whom that happened. So I send a lot of patients to Wayne for this. I think he's a really good doctor. And actually, I go to him myself. But suffice it to say, he's contributed a lot to what we know about PXE of the eyes. As have the other eye doctors that I just mentioned to you. So, and there are studies that they can do to identify angioid streaks, but probably the most important thing and I will say, so back in the day, in the 1980s when they did this, the percentages of patients that went on to be legally blind was close to the majority of patients. A very high proportion of patients became legally blind, and certainly visually impaired was almost everybody. That has changed dramatically, and it's changed because of these angiogenesis inhibitors that are injected now. So I told you that what happens in PXE is you get these leaky blood vessels behind the retina. In the old days, if you would see, and here's the picture again of those angioid streaks. So this, by the way, is a slide which these really look like blood vessels, but this is loaded with angioid streaks, and they look like blood vessels to anyone who's not good at seeing them. But it is loaded with angioid streaks. So anyway, what we tell patients to do, okay, I'm getting to the point of what you can do, but when those blood vessels become leaky, straight lines become wavy. And this is an artist's rendition of what happens in macular degeneration, where the same thing happens. Patients develop leaky blood vessels, it changes the shape of the retina, and straight lines become wavy. So this is an artist who had leaky blood vessels in one eye, but not the other. And he painted this picture, and then he painted what it looked like in the bad eye, with the bad eye. And you see those straight lines that are, are you with me, Georgia? Am I getting ahead of you?
Nope, you're good.
Okay, so go to the one that has the straight lines with the good eye. And then the next slide is the wavy lines. And that's with the bad eye. So notice those straight bars suddenly become wavy. So in the next slide, what you see is something called an Amsler grid, which we still use to this day. And if you, once a week, you should hold it up and look at that middle dot and look if any of the bar graph lines become wavy. And if they do, that tells you that the shape of your retina is changing and that you have those leaky blood vessels. So in the old days, we treated those with laser. Every time we used the laser, though, we burned a little hole in the retina, and that led to a little area of blindness. And if it got close to the macula, which is the area of central vision, you literally, the laser itself could lead to blindness. So now we have something much better. We inject these agents that reduce new blood vessels. They make them shrivel up. And by doing that, we don't endanger the retina, and patients are able to retain their vision. And I did show you a few slides back that 15% still become legally blind, 37% are somewhat visually impaired. But certainly the numbers are dramatically better. I mean, we don't have a lot of patients becoming legally blind anymore. And back in the day, everyone did. Okay, let me go to the next slide, which talks about elastic fibers in valves. And so this actually, you know, I will say I'm proud that, you know, we were the first to identify this in the mitral valve. And it turns out that people who have a mitral valve prolapse often will have abnormalities of the elastic fibers, not just PXE patients. And here in the next slide is a picture. It's an artist's rendition of what mitral valve prolapse looks like. So on the left-hand side, you see a normal mitral valve. On the right-hand side, our valves are calcified in PXE, but when you get lengthy valves, lengthening of the valve prolapses. It actually fills when the heart, when that left ventricle fills up, which is the chamber of the heart that the valve protects essentially, the blood actually pushes back against the mitral valve and makes them balloon into the atrium, which is the chamber of the heart above the ventricle. And you can actually hear a snap, which is the mitral valve prolapse that we hear. So so what can you do? You can get an echocardiogram to see if you have this. Now, the dealing with mitral valve prolapse is very variable. If it is asymptomatic, the question was raised whether anything needs to be done at all. If somebody with a mitral valve prolapse has a very rapid heart rate because of it, there are drugs we can give you to slow down your heart rate. That is not often the case. We don't usually have to do that. In the old days, everyone with mitral valves was told that they should take antibiotics before dental work. And that has been thrown into question as far back as 1985. The reason it was thrown back into question is that the feeling was that we were developing a lot of antibiotic resistance to so that bacteria were not sensitive to antibiotics because we were using too much for prophylaxis for heart patients, patients with heart valves. And so for many years, we stopped using antibiotics unless the valve change was severe. And most of the time we don't. Recently, that has been thrown into question, and it is being suggested again that patients with mitral valve prolapse should receive antibiotics. I am not a cardiologist, and I'm not going to even weigh in on this, but I think that it probably is smart if you have a heart murmur to have an echocardiogram to see if you have what valve is abnormal, and if it is any of the valves, then speak to the cardiologist about whether they think you need antibiotic prophylaxis. I will say, if you are having a surgery or a dental procedure on an area that's infected, whether you know there are a lot of bacteria, it probably is worthwhile taking the antibiotics just to make sure you don't get a heart valve infection, because the valves are not normal. And again, this is a recent publication suggesting that you should take those antibiotics. I would defer to your cardiologist. Okay, what about heart attacks? We spoke about that. So again, here's the slide showing teenagers getting heart attacks. And I told you we had figured out a way of diagnosing PXE in young people who had heart attacks, but who had did not have skin lesions, but had angioid streaks. So there are several risk factors for heart attacks apart from PXE. Unhealthy diet, and anyone who's been to me knows that I give them a little tear-off sheet with a list of high and low cholesterol foods. We should all be trying to stick to the low cholesterol foods. Lack of exercise, and exercise is interesting in PXE because one of the things we don't want to do is increase the pressure in the blood vessels in the eyes. So exercises where you bear down, like, when you have to have a bowel movement, where you squeeze down, like weightlifting is one of those exercises. You have to like bear down to lift up the waist, are probably not good for your eyes. Exercises where you get hit in the head, like boxing or soccer, are really something a PXE patient should not do. Aerobic exercises, jogging, swimming, things where you move a lot are excellent for preventing heart attacks and should be something you should all be doing. Dancing. Smoking is really something you're asking for trouble if you're smoking, even if you don't have PXE, but certainly if you have PXE, you're asking for trouble. Obesity. Being overweight is a risk factor for heart attacks. If you have diabetes, you have to control it very well, because that is a risk factor for heart attacks. High blood pressure is a risk factor for heart attacks and must be controlled. High cholesterol is a risk factor for heart attacks and must be controlled. Alcohol, it turns out, is a risk factor for heart disease. So certainly there are two reasons to be cautious about alcohol. One is the impact it has on the heart. And I'm not saying that one drink a day of red wine isn't good for you or is bad for you. What I'm saying is over drinking is bad for you. And in particular, over drinking and banging your head is particularly bad for you. Okay, and stress, of course, is bad for everything and has been considered a cardiovascular risk factor. Now, apart from the narrowing of the arteries around the heart, what you're looking at here are endoscopic findings. You're looking at blood in the intestines, and blood vessels, I told you, become calcified, arteries become calcified, and they can crack and bleed. So, and here you see that calcified internal elastic lamina of an artery. That's the most beautiful picture I've seen. This is taken with an electron micrograph. So it's magnified many times over. So what can you do about bleeding? Well, bleeding can occur in the GI tract, the uterine tract, in the brain. It can occur in the kidney, in the bladder, and in the joints. And those are all, by the way, reports from PXE patients. So you want to avoid blood thinners like aspirin. And this often becomes a discussion with vascular surgeons. And there are some conditions and procedures where the chance of dying from a clot exceeds any risk you have from a blood thinner. And I will say, we do an eye exam. If the patient has new blood vessel formation and we think they're at imminent risk of losing their vision, we treat that before we put them on a blood thinner. But if there are circumstances where patients must be on blood thinners, drugs like indomethacin, ibuprofen, indomethacin is in Aleve, ibuprofen is in Advil. These are, and aspirin, those are drugs that make you bleed. Celebrex, the brand name is celecoxib. Actually, Celebrex is a brand name. Celecoxib is the generic name. That does not make you bleed. So we much prefer Celebrex to other NSAIDs. You can have your stool checked for blood, and there are actually all these new contraptions coming out to see if you're bleeding in the intestines. But a simple test like stool for blood is something an internist can do. And of course, if you are bleeding, those blood vessels can be cauterized or electrodesiccated. And in severe cases, you need surgery. We've had patients who had, with PXE, who've had broad areas of their intestines just diffusely bleeding. And the only thing that would stop it, and this is life-threatening bleeding, the only thing that stopped it was cutting out a piece of bowel in order to allow them to survive. And they did. We've had several, that happened a couple of times. Okay, so here are the calcified blood vessels. Do we have anything that can reverse calcification? And the answer is we hope so. So I told you that Yoni Wido and his team discovered the mutation, autosomal recessive mutation. By the way, there was a race going on for this gene, and he, of course, won the race. There was another group from Germany that about 2 weeks later published the same data. I also gave them the specimens. I actually, when I take specimens from a patient, I feel like, the purpose of this is to help everyone with the disease. And even though there was a race going on, we wanted, what we wanted is the gene. It didn't matter to me who found it. And I told you that there can be genetic heterogeneity. It's more than one gene, actually. So we are finally at a state where, thanks in large part to Dr. Wido, we have developed treatments that may help PXE. And he developed knockout mice where he knocked out the ABCC6 gene. Those mice developed lesions that looked exactly like PXE. And I am a little short on time, so I'm going to race through the dietary things that you can do, but I will summarize in detail what you can do. So the mutations are the two that you see here. They result in a reduction in something called inorganic pyrophosphates. It turns out that inorganic pyrophosphates take calcium out of tissues. And when you reduce it, you get elastic tissue calcification. So how do we get inorganic pyrophosphates back in order to make that work? And I'm going to show you a few slides which show that in patients with PXE, inorganic pyrophosphates are reduced. And that's why they get calcification of tissues. I'm going to race through these. And a really major breakthrough was made by Icahn. And they have a biologic. It is a fusion protein. So they take the human fragment from an antibody and they fuse it with the part that a part of a gene, ENPP1, that then it acts like ENPP1. So you're almost, even though the enzyme may be defective, you're acting like ENPP1 is there, and it stimulates what ENPP1 normally does, and it causes an increase in inorganic pyrophosphates. And as I just told you, if you have inorganic pyrophosphates circulating, they reduce calcium in tissues and they take calcium out of the blood vessels. For the record, when we introduced many of these treatments, we always worried, would we be causing osteoporosis because we're taking calcium out of tissue? It turns out that they preferentially take calcium out of other tissues, not out of bones. So we don't get we don't get osteoporosis from these drugs. Does diet impact PXE? So I'm going to race through these and get to the bottom line. We actually did large studies. In fact, I'll tell you an interesting thing about one of the studies. We used something called phosphate binders. The name of it was sevelamer hydrochloride, and it seemed to work. The problem was we didn't realize that the placebo that had been provided, and back then we didn't know magnesium helped PXE at least in animal models. And so our placebo had a ton of magnesium. And we found that our patients got better, but the placebo patients got better too. And so you see here that the improvement with placebo was 72%. The improvement with the phosphate binder, we thought a phosphate binding would improve it, was 83%. Well, it turned out, and we showed the same thing here by image analysis that we did. So a little joke for you, it works on humans, but we don't know about mice. So Dr. Weedo had developed this mouse model for PXE, and they showed that the treatment, the phosphate binder you did not improve PXE, and phosphate binding did not work for PXE. But what they showed is that magnesium did. And if they were mice were put on a high magnesium diet, 5-fold increase, there was no evidence of connective tissue mineralization. They didn't get calcification, even though we had knocked out the PXE gene. So, we scratched our heads, and I went back to the original study, and we asked the placebo maker what was in it, and it turns out it was loaded with magnesium. So we thought we were onto something. Many other people showed that magnesium in animal models prevents PXE, and I'll race through these. I'm going to tell you, Georgia, because I'm going quickly. I'd like you to go to slide number, see what number it is, 74.
What's the words on it?
It says dietary magnesium, not calcium, prevents vascular calcification in a mouse model for PXE. And I hope everyone's been able to follow and go 3 slides forward. And again, another slide showing that magnesium reduces carotid thickness in a mouse model of PXE. And so in the next slide, number 78, you'll see that we actually did a trial of magnesium in PXE. And anyone who knows about studies, I'm going to show you the next slide. So look over here, and in red, you're seeing the placebo group, and in blue, actually, let me make sure I have that correctly. Look in the top line. I actually got that wrong. In blue is the placebo group, and red is the magnesium group. And what you're seeing is, no, I'm sorry, I got it right. Red is the placebo group, blue is the magnesium group. So in blue, over on the left, you see a lot of the blue going down. There's a reduction in calcium. On the right, going up is the placebo in red. And you see that the patients on placebo on average are getting worse. The patients on magnesium on average are getting better. And go to the next slide where you see these orange bars. So 8 out of 21 patients treated with magnesium had a 30% reduction in calcification over a year. In the placebo group, it was only 3 out of 19. Anyone who knows about statistics knows that when you have a small number of patients, you really need big numbers to make it statistically significant. And so this was not statistically significant. So it was a failure, but you can see that there's a clear trend in favor of the magnesium diet. So to this day, I actually do suggest to my patients that they might think about taking a magnesium supplement. I will say there is a lot of data, old and new, suggesting that calcium supplements might make PXE worse, but there is also data suggesting it doesn't. But what is known, so that is slide number 81. That's the next slide. And then going to the next slide, slide number 82, etidronate is a bisphosphonate. It's the drugs that are used to reverse osteoporosis. And it turns out that both in mouse models and indeed even in patients, you get a reduction in calcification when you use etidronate, this phosphate binder. So when patients call me, I'm osteoporotic, I need to take calcium, can I do that? The answer is yes, they should take the minimum daily amount required because you don't want to get osteoporosis. And there are patients with PXE who have developed osteoporosis, but they can take these bisphosphonates, which actually reverse osteoporosis, and it may actually help PXE. Okay, let me go to, and again, slide 83 shows other data. There's several data showing that. Now, slide 84 is interesting because it's about giving oral pyrophosphate to prevent calcification in ABCC6 in PXE knockout mice. And you go to slide 85, and there are now studies showing that if you use this, one of the problems with inorganic pyrophosphates, Cheese Whiz is high in pyrophosphates, but it's got a ton of salt, so it's unhealthy for you. So this shows that they have a sodium-free preparation, which I believe they've patented, inhibits calcification of vessels in PXE knockout mice, and it is tolerated by healthy volunteers. And I do think that we have two medications now on the horizon. One of them will be this dietary supplement. I don't know if it will work. Certainly the inozyme fusion protein has been shown in the blood to clearly do what you need in order to take calcium out of the skin. And I'm waiting for them to announce a real trial, a phase 2 trial, to show that in patients we can reverse the calcium, not just in the skin, but in the blood vessels. Okay, so let me go to the third to last slide, which is slide 86. And so what you can do for our patients now, you should have regular retina exams at least every 6 months and use that Amsler grid that I described. You should live a heart-healthy lifestyle with a low cholesterol diet, exercise, don't smoke, control diabetes, hypertension, and weight. If patients develop intermittent claudication, there are actually things that can be done. There are stents that can be put in that help that if it is severe. No procedure is perfect, though. Cardiac valvular disease, if it is severe, there are many things we can do about that. For bleeding, of course, we can reverse that. You want to avoid aspirin and blood thinners. As far as diet, and other things, there are questions. Does oral magnesium help? I believe it does based on the study we did, but it was not statistically significant. And I think, somebody who doesn't know statistics will kind of ignorantly dismiss it. It turns out that, anyone who does know statistics knows you need a much bigger trial than the small study that we did to make it statistically significant. Avoiding birth control pills has been suggested. The evidence is not great for that, but there is some data suggesting that oral contraceptives make PXE worse. I don't know if a low calcium diet helps. I do know that we don't want our patients to get osteoporosis, so I give everyone actually a list of high and low calcium foods, and I ask them to try to hit the 1,200 minimal daily requirement a day units of calcium that they should get, milligrams of calcium. Bisphosphonates are questionable, and I'm hopeful that this inorganic pyrophosphate and also the molecule made by Inozyme will be future treatments, and hopefully we'll hear more about that in the near future. So next slide, if you want information, there's my email address, lebwohl@aol.com, and I can't say enough nice things about Sharon Terry and PXE International. They have really when we finally get a treatment, it will be thanks to them. And in the last slide, there's a picture of Sharon and of Yoni Wito. And my last slide is, I hope I didn't put you to sleep. So thank you very much. And I do have a few minutes for questions.
That was great, Dr. Lebwohl. Thank you so much.
My pleasure.
Good.
Great, yeah. And if you have a question, you can either put it in the chat or raise your hand or just unmute yourself. We've got about 5 minutes, so try to keep your questions brief.
It's Samantha Goldman. I have one question. There was a slide that we slipped through, and it said something about vitamin D, not to take it, which of course I take.
Yeah, I don't believe that, but it was published in 2022. It's a very recent publication.
Okay.
And I actually don't believe it. But you know what vitamin D is? It causes your body to intake more calcium, but it usually goes to the bone. So I do not restrict vitamin D in my patients. That publication was pretty recent. And, you know, maybe we'll get more data on it, but you're correct. I don't want my patients to get osteoporosis is the problem.
And how many milligrams do you think maximum for a PXE a day?
Most people get adequate amounts of vitamin D from their diet and from sun exposure. If your vitamin D is low on a blood test, and it's now become pretty part of a usual screening by just a GP. If it is low, then we supplement it. And normally I give 2,000 international units a day to someone who's low. And I don't see a reason to change that for PXE patients.
Thank you.
Sure.
Mark, we have a question in the chat. Are there plans to do a larger study with magnesium supplementation?
You know, I think the magnesium story became much less important when the inorganic pyrophosphate story came about, because here we're going right at the cause of PXE. Magnesium hits it indirectly. The inorganic pyrophosphates, whether diet or the inozyme injection, really get to the heart of the matter and reverse it easily and quickly. You know, the kind of graph that I showed you where it didn't reach statistical significance would be very lopsided, certainly with the inozyme molecule, where it dramatically impacted inorganic pyrophosphates in the blood.
And you can learn more about that current phase, I believe phase 1/2 trial on our YouTube channel. That was Yve's presentation for anyone wanting more information.
Yep.
I think we maybe have time for one more question if anyone has one.
I must have told him everything. Okay. Well, thank you everyone for having me. I never mind being called about PXE. Often you've had the experience, I'm sure, of going to physicians who never heard of the condition, and I never mind explaining it to them. So, feel free to use that email address I left you.
Great. And thank you so much for taking the time to do this presentation. It was really great, really informational. Hopefully I kept up with the slides fast enough. But just as a reminder, this will be on our YouTube channel, so you can go back and view it anytime. Probably early next week, we'll have it up. So hope everyone, for those on the East Coast, have a great rest of your evening and a good Easter weekend if you celebrate.
Yep. Happy holidays, everyone. Take care.
Thank you.
Thank you.
Okay. Bye-bye now.